Hello, everyone, and thanks for joining today's webinar, Vaccinating Every Child, Promising Strategies for Reaching Zero-Dose Children in Mali and Uganda. Please continue to introduce yourselves in the chat, your name, country, and role, so that we can all get to know each other. My name is Erin Brookhazen, and I'm the project director for the Gavi Zero Dose Learning Hub at JSI. It's a pleasure to have you join us today for the Zero Dose Learning Hub 2024 webinar series. The Zero Dose Learning Hub addresses immunization equity through the generation of evidence and learning around effective methods and approaches for identifying and reaching zero-dose and under-immunized children. The Zero Dose Learning Hub supports 4 country learning hubs as they advance their uptake of research and evidence to improve immunization policy and programming, especially at the subnational level. Next slide. Before we start today, let's take care of a few housekeeping items. For those who would like to continue the webinar in French, please click the interpretation icon to set your channel to French. Those who wish to stay with us in English, you will also need to click on the interpretation icon to set your channel to English, as we will have interpretation from French to English, and you'll need to have selected the audio channel to hear it. Pour écouter le webinaire en français, cliquez sur l'icône d'interprétation pour sélectionner le canal audio français. Ceux qui souhaitent écouter le webinaire en anglais devront sélectionner le canal audio anglais. Next slide, please. Please submit your questions for the panelists in the Q&A box. Panelists will either reply back to you via text in the Q&A box or will answer your question during the discussion portion of the webinar. If at any point during the webinar you are unable to hear, please make sure you've connected your audio by selecting the headphones icon at the bottom of your Zoom window labeled Join Audio. If you still cannot hear the presenters or see the presentations, try leaving the meeting and joining it again with the link provided. Please send a message to everyone to send in your questions or comments for today's speakers, or ask for support during today's webinar. We have a support team monitoring the chat and able to provide further assistance. Closed captioning in English has been enabled for this meeting. To view the live English subtitles on your screen, click on the CC or closed captioning icon and select Show Subtitle. Please note that this is being recorded, and the recording will be shared via email and will be made available on the Zero Dose Learning Hub website. Next slide, please. Now it is my pleasure to introduce this facilitator for today's webinar, Dr. Gustavo Correa, a Senior Program Officer at the Measurement, Evaluation, and Learning Department at Gavi. He leads the Zero Dose Learning agenda for the Gavi Secretariat. Thanks again for joining today, and I'm happy to hand it over to Gus to kick off the webinar and introduce today's speakers. Gus, the floor is yours. Thank you.
Thank you very much, Erin, for this wonderful introduction, and welcome everyone for today's webinar. Today, we're going to discuss the reach strategies of the Zero Dose Learning Hub of Uganda and Mali. And I just wanted to make a few brief introductory points about the project and what we're going to discuss today. The Zero Dose Learning Hub is part of our learning agenda. It's our flagship project, our main prospective projects, and it's learning about zero dose approach in 4 countries: Bangladesh, Mali, Nigeria, and Uganda, with a global learning partner that is JSI Consortium helping us today. They generate evidence on zero dose programming at the country level. They are embedded in the country programs and align with the country zero dose learning agendas. This project supports learning and funds some learning activities and implementation research for zero dose interventions, but do not fund the interventions themselves. The interventions may or may not be funded by Gavi, but they respond to country-specific learning needs. We hope the project will shed light on what works and what doesn't work, and on key enablers and drivers and barriers for countries and the Alliance. This webinar will focus on the REACH component, as I said, at the country level. This is part of a series of 2 webinars highlighting and discussing the diversity and the variation of REACH approach per different types of contexts and different typologies of zero-dose communities. Because zero-dose children tend to cluster in pockets of communities under multiple deprivation, the zero-dose learning hub approach is also very targeted to be able to generate evidence on those pockets. The objective is not to generate learnings that are representative for the whole country, but rather make deep dives on specific communities of interest. That also highlights the need for a good theory behind the program that country learning hubs we also discussed today. These theories, they are very useful to better understand the context and the barriers of specific contexts and what needs to be done to change those barriers. That provides a good basis to understanding how the programs are progressing, to inform enhanced monitoring approach that will be part of the research you're going to see today, and how good a fit the intervention may be to promote change in the different contexts. A good theory is also very relevant to inform generalizability of the findings, acknowledging the complexity of those different settings. If a theory works to promote change in those specific settings we're going to see today, there is also a good chance that they will also work in other similar settings facing similar barriers. Quantitative and qualitative data enhance the understanding of how these programs are working and are part of this implementation research. So with that introduction, I would like now to introduce today's speakers and discussants. Starting with Dr. Zakaria Keita, who is a medical epidemiologist and a research coordinator at the University Clinical Research Center of the University of Science, Techniques and Technologies of Bamako, which implements the training program on implementation research for World Health Organization interventions in Mali. Dr. Keita has more than 10 years of experience in public health research programs and the operationalization of the One Health approach. He won the Innovation and Communication Prize at the World One Health Congress in Singapore in November 2022. I would also like to introduce Carol Kemia, who is a Senior Evaluation Officer in the Uganda Country Learning Hub for Immunization Equity, working with the Infectious Disease Research Collaboration in Uganda. She's a health economist with over a decade of experience in health financing, health systems, health equity, monitoring, and evaluation. Finally, I would like also to introduce Grace Chi, who works for JSI and serves as the project director for USAID's Momentum Routine Immunization, Transformation and Equity, the MRIGHT project. This project works in 20 countries to support immunization programs. And Grace has more than 25 years of experience in health financing and health system strengthening, as well as immunization financing and evaluation of immunization programs. Now we can start our webinar. Pour ceux qui veulent continuer les webinaires en français, vous pouvez cliquer sur le bouton interprétation pour sélectionner les canaux audio français. For those who wish to stay in the English channel, you will also need to click on the interpretation icon to set your channel to English, as we will have interpretation from French to English as well. Alors là, maintenant, c'est mon plaisir d'inviter le Dr. Keita, qui va faire la première présentation aujourd'hui. Je voulais juste, on va transitionner maintenant les systèmes de audio. We're going to switch the audio system now. You don't have to do anything. Vous ne devrez faire là maintenant aucune action. Juste, c'est la transition des traducteurs dans le système. Une petite pause qui, je pense que là maintenant, c'est déjà résolu. I think now they are probably ready. And we can start our presentation. On peut démarrer maintenant. Dr. Keita, bienvenue.
Bonsoir à tous. Merci, Dr Gustavo, pour cette excellente opportunité. Merci à Gavi qui nous donne cette opportunité de présenter sur euh, nos, nos innovations pour réduire le nombre d'enfants 012. Moi, je suis de l'Université des sciences et des technologies de Bamako et je présente ce travail dans le cadre du consortium Ghanached, qui est composé de Ghanached, l'université et le CVD au Mali. C'est pour faire une évaluation de la mise en œuvre de deux innovations pour renforcer l'offre de vaccination dans 4 typologies de districts sanitaires au Mali. Diapo. On va suivre le plan suivant pour cette présentation. Diapo. Le Mali vient au 7e rang en Afrique avec le plus grand nombre d'enfants 012. Et le nombre d'enfants 012 était estimé à un peu plus de 136 000 en 2020. Et la couverture vaccinale pour tous les vaccins de base au Mali était estimée à 45% selon la dernière enquête démographique de santé au Mali. Et les vaccins Penta 1, la couverture du vaccin Penta 1 qui est considéré du vaccin diphtérie, tétanos, coqueluche, du vaccin hémophilus influenza B, du vaccin contre l'hépatite à 82% et les Penta 3 à 77%. Il y a une carte des zones prioritaires potentielles qui a été identifiée sur la base des zones de faible couverture vaccinale et un nombre élevé d'enfants. Et on retrouve des régions du sud et des régions du centre, comme la région de Mopti et la région de Koulikoro. Et on retrouve aussi des régions du nord, telles que la région de Gao. Diapo. Donc, au Mali, il y a des obstacles courants et spécifiques à la vaccination qui ont été identifiés par les centres d'apprentissage pour l'équité vaccinale. Et parmi ces obstacles, on a des obstacles qui sont communs et on a des obstacles qui sont spécifiques selon les différentes typologies des districts. Commençons d'abord par les obstacles communs. Parmi les obstacles communs, on a les obstacles qui sont liés à l'offre de services, comme une insuffisance de stratégie, d'implémentation des stratégies, comme les stratégies mobiles avancées, des ruptures de stock qui sont fréquentes, avec une faible intégration à la santé communautaire. Encore, parmi les obstacles communs, on a aussi les obstacles qui sont liés à la demande, comme le manque d'intérêt et de motivation pour la vaccination, les rumeurs sur les vaccins et les pertes des effets indésirables. On a aussi des obstacles communs liés au genre, comme un faible pouvoir décisionnel pour la femme, un manque de moyens de transport et les contraintes financières. Maintenant, de façon spécifique, selon les différentes typologies de districts, dans les districts urbains, ruraux, les zones de conflit et les communautés spéciales, on retrouve des obstacles à la vaccination. Par exemple, si on prend le milieu urbain, on a une insuffisance des stratégies mobiles avec une insuffisance dans la gestion des manifestations à la post-immunisation. On a aussi au niveau des districts ruraux, surtout une insuffisance dans le suivi du contrôle et une faible intégration avec les autres services. Pour les zones de conflit, comme une grande partie du pays est confrontée à l'insécurité, il y a souvent une indisponibilité des services de vaccination qui entraîne souvent aussi une rupture de stock de la chaîne d'approvisionnement. Au niveau des communautés spéciales qui sont surtout les communautés dans les zones d'orpaillage, au niveau des frontières et les déplacés, c'est surtout souvent des problèmes de chaîne d'approvisionnement en chaîne de froid et aussi une intégration limitée avec des ruptures de stock qui sont fréquentes. Diapo. Diapo. Okay. Ici, les deux innovations que le pays a choisies pour réduire le nombre d'enfants 012, c'est le coaching de la performance et le médicisme. Pourquoi le coaching de la performance? Parce qu'on a constaté des problèmes lors de supervision avec souvent un manque de suivi et de retour et un manque d'amélioration de la personne qui est supervisée. Donc, nous proposons les coachs super qui va assurer ce qu'on appelle une digitalisation de la supervision formative et transformer la supervision formative ciblée le coaching de la performance pour l'atteinte des enfants 012. L'agent pourra avoir automatiquement un rapport sur sa performance avec un tableau d'amélioration. Donc, il pourra automatiquement travailler avec l'outil là pour apprendre et corriger les failles avant la prochaine supervision. L'outil Code to Peb aussi permet aussi de mener des enquêtes sur la performance des programmes de vaccination. Pour le Medisix, puisque l'un des obstacles, c'était surtout les ruptures de stock à tous les niveaux, le Medisix va assurer ce qu'on appelle visibilité de bout en bout avec un système d'information de gestion logistique. Donc, nous pensons que ça pourra aider à vraiment réduire ces ruptures de stock et offrir plus d'offres de services de vaccination. Aussi, on a une possibilité d'intégration avec interopérabilité, diapo. Maintenant, la conception de l'étude de la recherche d'implémentation. L'objectif est vraiment d'évaluer les stratégies d'implémentation de ces deux innovations qui sont le coaching, le coach to PEV et le médecin dans les 4 typologies de districts sanitaires, urbains, périurbains, rural, éloignés et les populations sociales. Les questions de recherche que nous nous sommes posées, c'est surtout les innovations mises en œuvre permettront-elles de renforcer l'offre de services de vaccination et les indicateurs du programme élargi de vaccination. Deuxième lieu, est-ce que l'amélioration de l'offre des services de vaccination permettra-t-elle de réduire les enfants zéro dose dans les 4 types de districts au Mali, ou existe-t-il d'autres obstacles qui pourraient empêcher cette réduction? On a choisi la méthode comme type d'étude, l'étude quasi-expérimentale, avant-après, avec une évaluation du processus des déterminants et une évaluation d'innovation afin de réduire le nombre d'enfants zéro dose avec une approche mixte, qualitative et quantitative. Diapo. Le cadre conceptuel de cette recherche d'implémentation que nous proposons se déroule en 4 phases. Phase 1, enquête de référence. Phase 2, mise en œuvre des interventions du code to PEV et des médicis. Phase 3, enquête finale. Phase 4, recherche post-mise en œuvre. Pour la première phase, on va surtout faire des revues documentaires, la revue des données, des entretiens approfondis pour surtout ensuite pour faire une mesure de la couverture vaccinale, aussi étudier les barrières liées à la demande, à l'offre et au genre et les facteurs socio-culturels approfondis. Et pour cela, on fera des entretiens individuels aussi dans les ménages. Et cette phase-là va concerner surtout les responsables, les prestataires de santé au niveau du ministère de la Santé, des directions générales de la santé, du Centre national d'immunisation, des directions régionales de la santé, des districts sanitaires, des aires de santé et au niveau des ménages. Donc, on va surtout mesurer l'acceptabilité, la faisabilité, la pertinence, la couverture vaccinale, et les coûts et la fidélité. Pour la phase 2, qui est la phase de mise en œuvre du code supérieur des médecins, on va aussi, en plus des revues qu'on va continuer, on va faire de l'observation au niveau des centres de santé pour surtout mesurer la qualité des services, la performance du personnel PEV. Pour la phase 3, qui est l'enquête finale, on fera surtout des discussions de groupe, des entretiens individuels dans les ménages pour mesurer la couverture vaccinale encore, les barrières liées à la demande, l'offre, les facteurs sociaux, culturels et économiques. Pour la phase 4, qui est la recherche post-mise en œuvre, on va dire recherche post-marketing, va nous permettre surtout de mesurer une fois de plus la couverture vaccinale, les barrières liées à la demande, et à l'offre et au genre et les facteurs socio-culturels et économiques. Donc, ceci va concerner surtout les prestataires de santé, les leaders communautaires, les groupements de femmes et jeunes et les ménages. Donc, le titre se déroulera au niveau des 4 typologies de districts qui ont été intentionnellement sélectionnés parmi les 44 districts prioritaires au FPP en tenant compte de la spécificité de chaque district. En commune 6 de Bamako, Yoroso, Bougouni et Nyono. Diapo. Vu les obstacles liés à l'atteinte des enfants zéro dose, le pays a vraiment décidé de travailler avec ces 2 interventions et propose cette théorie de changement qui est basée sur d'abord l'obstacle majeur à l'équité vaccinale qui a été identifié, comme ça a été dit, c'est l'offre de services de vaccination insuffisante et inappropriée pour atteindre les enfants zéro dose et insuffisamment vaccinés. Et les interventions, le coaching de la performance et les médecins vont permettre d'avoir un personnel de santé compétent et motivé et une meilleure prévisibilité de la gestion des vaccins, avec comme effet la réduction du nombre d'enfants zéro dose et insuffisamment vaccinés. Diapo. Comme limite, c'est surtout des limites humaines liées à la résistance au changement de la part des professionnels de la santé et à l'instabilité du personnel. Il y a aussi des limites liées à l'insuffisance des ressources financières et matérielles et des problèmes d'insécurité de gouvernance. Diapo. En conclusion, ces deux innovations, le Code SUPEV et MEDI6, permettront de renforcer d'abord la qualité de l'offre de services de vaccination, la disponibilité des vaccins et les indicateurs du programme élargi de vaccination afin de réduire les enfants zéro dose dans les 4 typologies de districts. Diapo. Je vous remercie. Vous avez ici l'excellente équipe du consortium Ganachet. Diapo. Avec le CVD, le Centre pour le développement des vaccins au Mali, et l'USCTB, l'Université des sciences, des techniques et des technologies de Bamako. Les centres d'apprentissage pour l'équité vaccinale vous remercie pour votre attention. À vous.
Merci, Dr. Keita. Donc là, maintenant, on va transitionner de nouveau le système pour l'anglais parce qu'on va voir la discussion de Ouganda. Now we're going to switch in the background the system of the translators to the English. So just bear with us 1 second, and then we're going to have Dr. Carol Kemia that is going to come and present in English for the Uganda learnings. I think now it's ready. Dr. Carol, please, over to you.
Thank you so much, Gus. Good afternoon, good morning, wherever you are. My name is Carol, and I'll be presenting on behalf of the Uganda Learning Hub for Immunization Equity. As a background, the immunization coverage for Uganda has been relatively high, but despite these efforts to increase vaccination coverage, the estimates from DHI is to actually show that over 90,000 children are not reached with vaccination. And so the Uganda Learning Hub was born to generate evidence on identifying and reaching these zero-dose children. And specifically, we are looking to characterize the zero-dose child, but also to examine the implementation outcomes. Next slide. So objective 2 is honed around examining implementation outcomes of ongoing and planned immunization approaches to reach zero-dose children and under-immunized children, as well as mixed communities. And as part of the pilot for the implementation research component for the Learning Hub, we looked to evaluate UNICEF's zero-dose technical support as one of the ongoing interventions. And we are planning to evaluate the Equity Accelerator Fund interventions as well. The Learning Hub in Uganda is focused in 3 districts, and that is Wakiso, Mubende, and Kasese. And these have very many high-risk groups, such as urban settlements, mountainous areas, island communities, underserved areas, and mining areas, etc. Next slide, please. So in this webinar, we present some of the high-level findings of the evaluation of UNICEF's zero-dose technical support. Next slide. With this evaluation, we set out to assess the implementation of this technical support, but we focused this evaluation on 2 activities, and that is the house-to-house registration, as well as the default tracing in 2 districts, Wakiso and Kamuli. And specifically, we wanted to assess the different implementation outcomes, identify any enablers and challenges, as well as estimate the number and proportion of zero-dose and under-immunized children. Next slide, please. So this slide shows a simple bar graph of the number of zero-dose children identified. So out of the 12,900 children that were registered across districts, about 1,700 zero-dose children were identified in Kamuli district, and this is through the house-to-house registration by the village health teams, and about 600 zero-dose children were identified in Wakiso. And this is using the health facility definition that captures children who are aged 6 to 52 weeks without DPT-1. But when we consider the community definition, which only considers children aged 2 and above, we identified about the house-to-house registration identified about 300 in Kamuli district and 76 in Wakiso. However, the caveat here is that only 52% of the sub-counties in Wakiso had data, and so this might not be a true representation of the number of zero-dose children in Wakiso district. Next slide, please. So after identifying the numbers of zero-dose children, we actually use the data to map and see where these zero-dose children are according to the different sub-counties in Wakiso and Kamuli district. Even though we did not have data for most of Wakiso district, we're still able to map and identify where these zero-dose children are by sub-county, which is such an advantage for the house-to-house registration. But for Kamuli, where complete data, almost complete data was given to us, we saw a high number of zero-dose children marked in the yellow, marked in yellow in the different sub-counties. Next slide, please. So even though the house-to-house registration was successful to a certain extent, they still had some implementation challenges, such as the suboptimal reach of the house-to-house registration, given that only one village health team member was engaged, and yet you might find that so many VHTs are attached to one village. There's also inadequate training of village health team members in the context of resistant caregivers. And this was because they were not given prior notice about the activity. And several VHTs also reported that the registrars were quite bulky and not user-friendly. Next slide, please. So what do we learn from the UNICEF zero-dose technical support? It does seem that the house-to-house registration actually identifies zero-dose children. However, it's unclear whether all the children who are identified were actually reached with immunization, and its sustainability actually is still unclear. And then we're also not sure whether the house-to-house registration actually identifies those children who are systematically missed by the health system. And then another learning is that the presence of high numbers of zero-dose children in urban settings also suggests the need for targeted support in these areas. But it's also clear that identifying and tracking these zero-dose children requires a data capture system that not only collects individual data at the community level, but also facilitates real-time use of data at all levels. Next slide, please. So in line with that, we are planning to evaluate the interventions under the Equity Accelerator Fund. Next slide. As part of the Learning Hub. And prior to that, we conducted a rapid assessment in the 3 highlighted districts, and we identified several barriers faced by the zero-dose caregivers and families. There are several barriers, but some of the overlapping ones across the different high-risk groups include the fear of adverse effects from vaccines, the hidden immunization costs, the limited spousal support, long distances to health facilities, especially those areas with mountainous areas and island communities. And yet many caregivers still give birth at home with traditional birth attendants and are not linked to the nearest health facility. Next slide, please. So with this in mind, we are going to implement this research design in which we will employ both qualitative and quantitative approaches, which include document reviews, stakeholder engagement, key informant interviews, in-depth interviews, meeting observations, and community surveys, as well as analyze the secondary data that's available. Next slide, please. So the implementation research design will take on a pre-post approach. And as I said earlier, we'll use qualitative and quantitative approaches, and we'll have a process evaluation arm in which we'll have meeting observations and key informant interviews and in-depth interviews, as well as an impact evaluation arm, which has targeted community surveys, where the surveys are conducted before and after the interventions. The implementation research, as mentioned earlier, is being conducted in three focus districts for the Learning Hub. However, the survey will only be conducted in one district. We will focus the implementation research on national level stakeholders, district level stakeholders, way down up to the caregiver. And we were interested in caregivers of children of children who are aged 4.5 to 23 months. We intend to use the RE-AIM framework, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance or Sustainability. Next slide, please. So the EAF interventions, we have selected a few of the EAF interventions, but the caveat here is that the Ministry of Health is still trying to identify which interventions will be implemented where. However, they have prioritized some interventions to be implemented in the first year. And so this slide shows a few of the interventions that we are looking at evaluating, such as the house-to-house registration, the defaulter tracking, the geomapping of affected communities, and engagement of the private health sector, as well as engagement of health and non-health community structures. Next slide, please. So the theory behind these interventions is that they will use community-based data capture platforms to identify zero-dose and under-immunized children. They will track the immunization status of these children so that they can monitor immunization, as well as improve availability of immunization services, especially to hard-to-reach areas, and also engage health and non-health actors. So, and these are based on the assumption that there's availability of resources, there are adequate and willing human resource at community and health facility level. There's willingness of caregivers as well, and that interventions are sustainable and there are good partnerships at national and subnational levels. Next slide, please. Due to the interest of time, I will not go through the draft theory of change, but this is the theory of change that is heavily based on Patton et al. And it kind of encompasses the evaluation of interventions in complex systems in order to achieve the desired outcome. Next slide, please. So some of the limitations that we envision are, of course, the delayed implementation of the intervention, which will limit our ability to measure the effects, and also the limited generalizability of the findings due to the limited scope. Next slide, please. So in general, the Learning Hub have generated some relevant findings, and we hope to continue to do so. However, there's no structured, it's important to note that there's no structured theory of change or framework to support the planning and implementation of these routine activities, as well as the EA activities that are planned. But we know that, we hope that the findings from this evaluation will inform the design of the interventions to identify and reach zero-dose and under-immunized children. Next slide. The evaluation is being done by a team from Infectious Diseases Research Collaboration, Makerere School of Public Health, and PATH, who are shown here. Thank you for listening. Next slide. Merci.
Thank you very much, Carol, for this wonderful presentation as well. We will continue in English now, and I would like now to invite our discussant today, Grace T, to come in and also share her perspectives and ask the questions that she wants to ask. So, Grace, please, the floor is yours.
Thanks very much, Gus. And thank you for these two excellent and really informative presentations about the work in Mali and Uganda. First, let me speak to the presentation from Dr. Keita on the interventions in Mali. I don't know the situation in Mali very well, but I would assume that improving the quality of services through supportive supervision and reducing stockouts would certainly be very helpful to reducing zero-dose and under-immunized children. Just a few comments around the supervision work and how you're studying the effect. I think it would be helpful to understand how supportive supervision was being conducted prior to the intervention, how often it was being conducted, what the protocol was, in order to try and see the effect, both in terms of either increasing the frequency of supervision or how it was done. And then on top of that, the effect of having this supportive digital supportive supervision tool. I think there's lots of evidence that supportive supervision done well really does improve the quality of services and can also improve staff motivation. So I wanted to relate that to some work that we are doing on MRIGHT in Kenya. We're working simultaneously to try to address health worker motivation and performance, and at the same time to improve the experience of care for caregivers. So we know the caregiver experience during vaccination has a big impact on whether she completes the schedule. So if the health worker belittles her or yells at her, she might not come back, and we want to minimize that and ensure that caregivers return to complete full vaccination. I also wanted to mention an interaction I had recently when I was on a trip in Nigeria. And in Nigeria, they're using the RIS tool, the Routine Immunization Supportive Supervision tool, which is a digital tool throughout the country. And I saw it applied at a health facility. We discussed the different sections of the tool and some of the benefits of digitization. One thing that we learned in the course of doing that is neither the supervisor nor the facility keeps a record of the supportive supervision visit and some of the discussions during the visit. So unlike the old paper form, we weren't able to see when the last visit was, what the issues that were discussed were, and what any recommended follow-up actions were, and whether they were taken. So I just wanted to share that with you and encourage you, if it's not happening, or maybe you've already planned this, to enable access to previous records. And maybe the protocol might even start with a review of the previous findings, just to see whether sort of the appropriate follow-up actions have been taken. So these seem like very useful interventions. I wanted to ask Dr. Keita some questions around whether there are complementary interventions that are also being undertaken in order to improve accessibility. For example, are there more outreach services planned or additional hours or sessions planned? And then on the intervention around visibility into vaccine stocks, I think it's great to have more visibility, and we know we want to limit any potential stockouts. But I want to know, what are the protocols that are in place to, if you see that there is low stock or if there is stock out. And by that, I mean, is it clear who is responsible for resupply? Are there resources for transport of vaccines in that situation?
Yeah.
So maybe I will go on and provide some comments around Uganda, and Dr. Keita, you can come in to address that in a bit. I also found those interventions very interesting, and I was really struck by similarities with some of the work that we're doing on the MRIGHT project. In Mozambique, we also conducted community mapping in preparation for catch-up activities that was done earlier this year. What we found is that afterwards, when we went to vaccinate the children, in some places we were vaccinating more children than were identified through community mapping. So clearly we were undercounting at that point, and it's possible there wasn't enough time to count everyone, to map everyone in the period that was given. It was a 5-day period, but we're still working to see how to improve community mapping. Another learning from this activity is the importance of data review at all levels and at a very disaggregated level. In the 2 provinces where we were working, overall, we vaccinated 98% of the 0-dose and under-immunized children that were found through community mapping. So that sounds pretty good, looking at that number, except once you start disaggregating the data, we saw a lot of variation. So in some places, for some age groups, we vaccinated 120% of the children we found, while in other places, it was like 74%. So both those pieces of data show that there's room for improvement, either in the community mapping process or in the process to reach these children. Some of the interventions that are planned through the EAF, I also saw a lot of similarities with the work that we're doing, the MRI project is doing in Nigeria. We're also working in urban health facilities to introduce additional hours for immunization. So while the policy in Nigeria is to vaccinate every day, in reality, most places only vaccinate once a week. We're working with health workers and the in-charges in just a few facilities to provide services on 1 additional day. And the reason we want to do that in close collaboration with the health workers and in-charges is so that we can be sure this is something that's institutionalized, it's part of their routine practices, and they see the benefits from it, and it's not something that's dependent on our project to support. We're also exploring work with private sector providers, so we're very interested in what's planned in Uganda. And then lastly, one of the key approaches in the project is to work with community structures, both in terms of physical structures and organizational structures. So our approach has been to use sort of physical structures for community, for service delivery at the community level. So for example, providing services on market days in the marketplace, as well as sort of some of the organizational structures for disseminating key messages around immunization through religious leaders, physically at mosques and churches. We know this is really important for reaching all children, and we're very open to learning about new approaches to be able to be more effective at this. So my question for you, Carol, if I understand, there's a very limited time. You only have about 1 year to implement these activities. So I sort of have 2 questions is, do you have some interim measures in place in order to review the progress of activities and to see whether they're having the expected outcomes in order to be able to quickly make adjustments to improve implementation? And also related to private providers, we're really just very interested and want to learn how you're going about selecting them. Are you providing them training? Are some already equipped and providing vaccination? How are you setting that up for success? So I will end there and pass on to Dr. Keita and to Carol. Thank you.
Thank you, Dr. Grace, Chief, for your points and your questions. Before we move to Keita, we will continue in English and start with Carol, just to kind of not be too disruptive with the translation. So bear with us for a while longer in English. And Carol, would you like to come in and comment on Grace's comments for you and a question that she posed?
Yes, thank you very much, Grace. It's interesting to note that there are so many similarities in the interventions that are being implemented in Nigeria. And one of the things we've been struggling with, I guess, is the denominator. And I think it's going to be one of the challenges that we'll also experience as we evaluate these interventions. We have been relying on the Uganda Bureau of Statistics estimates to estimate the denominator right from national to subnational levels. And in some instances, we've ended up having negative figures. So this is something that we have on our radar, and we hope that these estimates will be improved by the recently conducted census this year. Of course, some of the interventions that are suggested by the EPI program are quite ambitious and they are resource intensive. We anticipate that they might not be as sustainable, but we're yet to see whether they will be sustained beyond the period of implementation. But some of them are quite resource intensive, especially if they're to be implemented outside of the project period. You asked a question about some of the interim measures that we will have given the delays in implementation of the EAF activities, and this is one of the limitations I highlighted. It will affect some of the measures that we have, especially if we are to measure the effect of the interventions in those specific areas. But we plan to strengthen the process evaluation component of the evaluation, both at national and subnational levels, through embedding ourselves in some of the meetings, conducting several stakeholder engagements so that we're able to map some of these outcomes, even though they might be delayed. Another thing I thought about was using existing data, even though there are certain caveats to using the existing data capture platforms, but this can be a good way to triangulate some of the qualitative findings that we get. We also think that triangulation of some of these findings with those of the implementers might be helpful, such as the CSOs and the private health institutions that are going to be involved in implementing these interventions. However, of course, given that the implementation period keeps changing, it's quite a big barrier, but we hope that by strengthening the process evaluation, this will help. With regards to involving the private providers, we are not engaging the private providers as a learning hub. However, EPI has a memorandum of understanding with some of the private health facilities in which they're able to provide immunization services. So some of the interventions that we've selected are actually geared towards that, so that we're able to kind of evaluate that interaction to see whether it can work, or and what, if it's not working, what things can be changed so that it can improve the immunization outcomes. Thank you. I think I have covered most of the questions and comments. Thank you.
Thank you, Carol. I have still some questions from the audience for you, and I will ask them. Just bear in mind, we have only 2.5 minutes before we transition to Mali. But let me try to pose that to you. There is one question related to the engagement of the non-health actors and the partnerships for advocating for immunization services. Which groups are engaged, and what progress has been made so far? Can you comment on that? If there is any progress at this stage?
Quickly, there's no progress at this stage, given that they're trying to prioritize and map out the interventions. But the non-health actors range from different, from education to CSOs to the private sector, and other institutions that are outside the health department. Over.
Another question related to vaccine hesitancy in immunization in rural communities. I know you did a rapid assessment in a community survey. Is that an issue that you identified as well in Uganda? And is there any strategy being planned in the EAF to address that?
Yes, it was a very big challenge that we identified during the rapid assessment in the focus districts. The EAF at the moment has several social mobilization strategies that they are planning to implement, and these really are around engaging the community and also involving the caregivers and passing on knowledge about immunization. But yes, to answer the question, there are quite a number of activities that are developed around social mobilization to address the vaccine hesitancy in Uganda. Over.
Thank you very much, Carol. I think we need to transition now to Mali. We would like just to give a quick minute for the interpreters to switch the system as well again. On va maintenant transitionner pour les Français. Je voulais juste laisser quelques secondes pour les traducteurs pour changer leur système. Je crois qu'à ces moments, ça doit être déjà bon. Donc là maintenant, Dr Zakaria Keita, merci pour votre présentation aussi. Est-ce que vous voulez commencer par répondre les questions posées par Dr Grace T, s'il vous plaît?
Oui, tout à fait. Merci beaucoup à Dr Grace T et merci à vous, Gustavo. Je pense que j'avais noté les questions. La première question, c'était de savoir s'il y a d'autres interventions complémentaires qui peuvent contribuer à améliorer les services qu'on fournit au niveau des zones rurales, par exemple. Et je la remercie pour l'excellente question. Effectivement, il y a d'autres interventions complémentaires qui peuvent contribuer à améliorer l'accessibilité, comme elle a mentionné dans sa question. Je dirais, dans les zones rurales, par exemple, il faut renforcer les services de proximité en renforçant les stratégies déjà existantes, comme la stratégie avancée et la stratégie mobile, où souvent il y a vraiment des problèmes de mise en œuvre. Et aussi, dans ces mêmes zones rurales, il faut aussi appuyer le renforcement de l'engagement communautaire, des agents de santé communautaire, qui est déjà vraiment prévu dans les FPP, qui est financé par Gavi. Et au niveau des zones urbaines, effectivement, il faut aussi des sessions d'air supplémentaires, comme le Mali a mis en œuvre une série d'interventions pour promouvoir l'équité, notamment la stratégie atteindre chaque enfant, destiné à fournir un accès équitable et durable aux vaccins aux populations difficiles d'accès. En outre, cette stratégie urbaine va être principalement déployée à Bamako, mais dans d'autres grandes villes aussi du Mali, et touche surtout les populations périurbaines. Et ces populations sont surtout les vendeurs ambulants, les mendiants, les migrants, et qui sont vraiment touchés par cette stratégie urbaine. Et je dirais aussi qu'il faut rendre disponibles les services de vaccination, même les week-ends. Donc, le Mali prévoit ça aussi en stratégie urbaine, de fournir dans certains districts en pilote les services de vaccination, même le week-end. Cela va permettre surtout aux mères qui n'ont pas le temps de passer les jours ouvrables pour qu'elles puissent vraiment avoir l'opportunité de vacciner leurs enfants. Donc, nous pouvons dire qu'il y a une forte volonté politique et institutionnelle pour vraiment atteindre ces enfants zéro dose et améliorer la couverture vaccinale. Elle a posé aussi la question de savoir les responsabilités par rapport à l'approvisionnement, les moyens de transport, et qui est responsable. Et je crois que c'est surtout, comme quand on voit la pyramide sanitaire du Mali, il y a le Centre national d'immunisation qui se trouve au niveau de la Direction générale de la santé, qui est vraiment responsable de l'approvisionnement du vaccin au niveau des différentes régions. Et au niveau de chaque région maintenant, ils vont déployer dans les districts sanitaires. Et chaque district sanitaire va déployer, est responsable du déploiement du vaccin jusqu'au centre de santé communautaire, qui sont les aires de santé. Et en ce moment, cela peut garantir l'accès du vaccin jusqu'au dernier kilomètre par les prestataires de santé qui se trouvent à ce niveau de l'aire de santé. Je vous remercie. À vous.
Merci, Dr Keita. Il y a des autres questions qui viennent maintenant de l'audience. Si vous pouvez poser un peu vos réflexions sur comment la formation, la supervision formative peut être intégrée dans les projets de recherche opérationnelle? Quels sont les détails que vous pouvez donner sur cela? J'ai une autre question encore sur quels vous pensez qui sont les pas, les étapes les plus importantes pour les innovations, pour être bien mises en œuvre? Est-ce que vous pouvez donner un peu de vos perspectives sur cela?
Ok, merci. Merci beaucoup pour la question. La première question, si j'ai bien compris, je vais d'abord commencer à répondre par la dernière question, c'est-à-dire les étapes vraiment qui sont importantes pour la mise en œuvre des innovations. D'abord, il faut essayer de comprendre, avant d'amener l'innovation, il faut que l'innovation puisse répondre aux besoins des structures qui vont mettre en œuvre. Et dans le cas du Mali, ces deux innovations ont été choisies par les plus hautes autorités, en l'occurrence les centres nationaux d'immunisation, pour répondre aux principaux obstacles comme l'offre, la performance des agents vaccinateurs. Donc, il y avait un problème de coaching, pas suffisamment de rapports, non suivi des rapports, la qualité du superviseur et du supervisé. Donc, on pense qu'avec ce coaching-là, ça va résoudre ce problème. Donc, cette innovation a été choisie par les centres nationaux d'immunisation. Pour le médicis aussi, comme il y a des ruptures de stock, on sait que c'est déjà déployé pour gérer les stocks pour d'autres médicaments, déjà par le ministère de la Santé. Donc, une adaptation sera faite pour répondre à ces centres. Donc, le médicis aussi est choisi par le Centre national d'immunisation. Donc, pour cela, on peut dire que ça répond déjà aux besoins. Donc, pour faciliter vraiment l'implémentation de ces deux innovations, il y a des préalables. D'abord, avant la mise en place, comme on a dit pendant la présentation, il faut vraiment faire des entretiens individuels et des entretiens approfondis auprès des acteurs à tous les niveaux, du niveau depuis le ministère, comme on a prévu, des acteurs clés au niveau du ministère de la Santé, de la Direction générale de la Santé, du Centre national d'immunisation, au niveau régional et au niveau des districts sanitaires des aires de santé. Donc, ces entretiens vont permettre vraiment de savoir et d'étudier les barrières ou les facilités qu'on peut avoir pour la mise en œuvre de ces innovations. Et aussi, pendant la mise en œuvre, il faut continuer ces entretiens avec ceux qui mettent en œuvre pour recueillir leurs impressions ou les difficultés qu'ils ont et essayer de faire des adaptations à ce niveau-là. Et aussi, il faut rassurer, puisque ça répond aux demandes du pays, en troisième phase, et faire une évaluation de l'effet ou de l'impact pour vraiment mesurer est-ce que ces deux innovations-là ont permis d'atteindre les objectifs qu'on s'était fixés au départ. Merci à vous.
Merci, Dr. Keita. Nous arrivons à la fin de notre webinaire. On a quelques questions qu'on n'a pas réussi à répondre, mais on va essayer de répondre à toutes les questions et partager après. Je voulais à ce moment dire un grand merci à tous les participants de pouvoir venir et participer à cette riche discussion. Les enregistrements et les diapos seront publiés, seront faits disponibles dans le site de Zero Dose Learning Hub. Ils seront aussi partagés par email. Et vous verrez que lorsque vous quitterez le Zoom, vous irez recevoir une enquête post-webinaire. Et nous apprécions vraiment vos commentaires et vos suggestions sur des nouvelles thématiques pour des webinaires dans le futur. Vous pourrez également vous inscrire dans notre newsletter pour recevoir des mises à jour par email sur des nouvelles ressources et webinaires Zero Dose dans le futur à venir. Donc, merci à tous les participants, merci à l'audience, merci pour vos questions et cette riche discussion. Et à bientôt à nos prochains webinaires. Merci.
Merci, goodbye. Merci, bientôt.